No one's presenting this week, right? And the week after is our exam. So next week is when we'll be able to get more review in. Today and in lab, you want to really just focus on this. This is your early time. And the neck's pretty complicated. So you could divide the neck into triangles, and you can see here, you can totally go overboard if you're obsessive compulsive with this. And I'm not asking you to do that. The one we typically want you to know is called the posterior triangle. I'm sure I have another slide on it, I forget. But the boundaries are sternocleidomastoid, clavicle, trapezius. So that's the posterior triangle. But you can subdivide everything, and I'm not asking you to do that. For example, if you were a surgeon specialized in neck issues, then you really want to know this. Triangles pretty well. The neck's a conduit, obviously for respiratory structures, lymphatic, nervous, GI tract, windpipe. The neck is an endocrine containing organ, right? The thyroid gland sitting in the neck. So a lot of interesting stuff going on in the neck. And so what I just drew for you is the posterior triangle of the neck, which is between clavicle, sternocleidomastoid, and trapezius. You could talk about the anterior triangle if you wanted, in front of the sternocleidomastoid. And then that you could even subdivide. How do you subdivide? There's muscles coursing through these triangles, but I'm not asking you to do that. So on the new body, we're almost at this stage where you just reflected platysma. You really want to approach the neck in layers. So like if you were dissecting, you'd have to go really gently, delicately in the front of the neck and try and extract platysma, which hangs off the jaw. It's technically a muscle of facial expression, and it kind of wraps like this, two hands on the front of the neck, kind of crunch up the neck. Really, it's one of those useless P muscles in my opinion. But it's a muscle of facial expression, so therefore it's innervated by cranial nerve 7, like other muscles of facial expression. And once you remove platysma, actually the way we typically do it is we keep it attached to the mandible so you can reflect it up. So imagine you reflect it up. And these muscle fibers here are representing platysma. And it is less than 1 millimeter thick. It's really difficult to dissect out of the skin, okay? If you do it, then you'll see connective tissue, but if you remove the connective tissue in an idealized world, this would be the next layer. Okay, so we're kind of at the layer of sternocleidomastoid. This is the layer where you can see the boundaries of the posterior triangle. One reason we care about the posterior triangle, let's change the color, is the brachial plexus first appears there. You can see it here. Okay. I think there's a cadaver or two, or at least on one side, you can still see external jugular vein coursing over sternocleidomastoid. Sternocleidomastoid. Its name tells you the attachments. It's attaching to the mastoid process of the temporal bone, and it's attaching to the sternum and the clavicle. So sternocleidomastoid. And coursing right over it is external jugular vein. Have we talked about function of sternocleidomastoid yet? No. I bet you there's at least one person here who knows what a bong is. Okay, I joke. So sternocleidomastoid is the bong muscle. That's good. Closest to work. Hi. Everything's good. Because it's attaching to the upper part of the rib cage, and any muscle that attaches to the upper part of the rib cage is an accessory muscle of inspiration. So you got your bomb, sternocleidomastoid. Now you got to turn your head to the side and then exhale. Sternocleidomastoid working unilaterally pushes the head to the side. So sternocleidomastoid, accessory muscle of inspiration. Sternocleidomastoid unilateral rotates the head to the opposite side. Exhale. Don't try that at home. Actually, in southern China, Yunnan province, northern Vietnam, you'll encounter a lot of people in villages smoking tobacco out of bamboo bongs. So bongs aren't just used for what you think they're used for, whatever that is, which I'm not advocating, I'm just saying. So that's the bong muscle, sternocleidomastoid, innervated by cranial nerve 11. So this is, I would call this the layer deep to platysma, the sternocleidomastoid layer, and we can see external jugular vein coursing over it. Of course, that implies that there's an internal jugular vein. And on the left side of this cartoon image, on the left side, you can see layer 3. To do this, if you were dissecting, you would typically, and you can see what they did here, you would transect, i.e. cut, sternocleidomastoid and its distal attachments and reflect it this way. You can see what's left of sternocleidomastoid right here. And in doing that, we reveal what's called the carotid sheath and its contents and the lateral aspect of the neck. And there's 3 main contents: carotid artery, internal jugular vein, vagus nerve. Now, in every body, we've already opened up the carotid sheath for you. I mean, if you don't, then you're missing all the fun in the neck. So, we've opened it up. So you can see here, actually, the 3 things in the carotid sheath. You can see carotid artery, internal jugular vein, and then usually a little bit deeper, peeking out, is vagus nerve, cranial nerve 10. Cranial nerve 10. Now, of course, the other things we see kind of at this plane are 2 sets of muscles, one attaching to the hyoid bone from above and one from below. And the ones from above are called suprahyoid muscles. This is all in future slides. And the ones attaching from below are called infrahyoid muscles. And generally speaking, if you contract a suprahyoid muscle, it elevates the hyoid bone. And generally speaking, if you contract an infrahyoid muscle, also called a strap muscle, because they look like straps, the hyoid bone will depress. Now, why do you need to move the hyoid? In swallowing, you got to elevate it. Sometimes for different kind of vocalizations, you got to move the hyoid. The hyoid bone's interesting. It doesn't articulate with other bones. It's kind of floating, and it's secured in place by ligaments and muscles. It's a weird bone. So that now they're showing you an even deeper layer on this view of the neck. This would be sort of like layer 3 or 4. We're at the endocrine layer. You can see the thyroid gland. You're even deeper to that. We're at the respiratory layer. And if you went deeper to that, you get to the GI tract. Of course, this is useful clinically, this particular anatomy. We've opened everything up here to the point where we can see the larynx, and which will continue with the trachea down here. If I said T, I meant larynx. I'm sorry. So the good news is you could do an emergency airway in an individual. One, maybe try it. If you can feel your Adam's apple with the finger, follow your finger down the thyroid cartilage until you don't feel cartilage. So right now I'm touching the cricothyroid membrane, the membrane between my thyroid cartilage that has the Adam's apple and the cricoid cartilage. So you can do a cricothyrotomy there, really easy to palpate, bang, done. Or you could go down further and do a tracheotomy. This is for an emergency airway situation, right? But the reason we can do that, two reasons. There is not any major artery in the anterior neck. Yeah, there's some small things, and there's some veins, but blood in veins is under low pressure. You're not going to hemorrhage a patient out if you do, typically speaking, if you do an emergency airway. The other thing is you don't have to go through the GI tract. You don't have to go through the pharynx or esophagus to reach the trachea or the larynx. So this anatomy here is pretty nicely situated, okay, for that. So actually, if you reflect platysma, and on the new cadaver they did a beautiful job. You can see it. It's on some other cadavers too. We flipped it, the new cadaver, so it's face up right now. You can see the superficial neck stuff on the new cadaver, but actually you wouldn't see suprahyoid or infrahyoid muscles yet, even after reflected platysma. What you would see is all of this deep fascia, and so there's a lot of layers of fascia, and I think the one I really want you to know mostly is carotid sheath. Okay. And but you can see like there's different kinds of fascial descriptions. I don't want to overburden you. You're not going to be doing neck surgery. I don't think this is important as PT students. But this is like similar to the deep fascia of the limbs that we've talked about, right? Fascia crura, fascia lata, okay? So it's fascia of the neck. The one I want you to know about is the carotid sheath. And like I just said, I'll say it again, 3 components: carotid artery, internal jugular vein, and coronary 10 vagus traveling down the neck. Of course, 10 now is becoming a really common site for neck surgery. They're implanting stimulation devices to stimulate cranial nerve 10 for many different kinds of conditions, from seizure disorders to all kinds of stuff, actually. So cranial nerve 10 stimulators. So this anatomy is pretty important there. Another reason this is really important anatomy is, you might end up being one of these people. I'm hoping you're not. You're in PT school. Most of you are probably really interested in staying healthy and physical exercise, but typical American diet actually, unfortunately, not that healthy, and eventually many of us end up with a lot of plaque in our carotid artery. The carotid artery at about C4, meaning the 4th cervical vertebra, bifurcates. Let me just show you this here. This is the midline of the neck. So this is common carotid artery on one side. Now, you might think, okay, it bifurcates into external carotid, internal carotid. I think the intuition would be this is external and this is internal, but you would be wrong. External is towards the medial side of the neck. External is the branch of the carotid artery that's giving off branches to stuff outside the skull. External branches outside the skull. Internal doesn't do anything in the neck. It goes into the skull and has a really cool convoluted S-shaped pathway through the skull that you can see with the radiograph. And internal supplies 80% of the blood to the brain. So arguably the most important artery in the whole body. So any place, now to get back to my point, any place where there's a branch point in an artery, so this is at C4 typically, where the carotid artery branches, this is a common place for plaque to build up. So if your diet, if you think the food pyramid, I would love this if this were true. It might be. It might turn out, science is always changing. If you think that the base of the food pyramid is donuts, right? Meaning this is the stuff you should be eating mostly. And the top is stuff you should just rarely eat. This is vegetables. Okay. We'll probably find out this is true. But okay, anyways. The problem with this sort of food pyramid choice, my friends, is you're going to end up with a ton of plaque right here. And so if you get 90% stenosis at that bifurcation place, then you become a candidate for an endarterectomy, finally getting to my point. And so then the surgeon goes into the neck, zips open the carotid sheath, and literally splices open the carotid artery. I'll show you the video if you want to see it. It's pretty cool to see it done. And then scoops out the plaque. It's unbelievable. And it's like as thick as my thumb, the carotid artery of most of us. So I have a friend who went in, older guy who went in 2 years ago. One side was 100% stenosis, so one of his carotid arteries was just completely blocked. So his brain was getting blood from the two vertebrals, which only supplied 20% blood, and one carotid artery. The other one was 100% stuffed with donuts. He got the wrong food pyramid teaching, whatever. And they went in and did an endarterectomy. He's great now. They just scooped out that plaque. Cool. Sorry, little clinical digression, whatever. Moving on. So, different fascial layers, kind of grouping together these different structures in the neck. And if you go behind the pharynx, in front of the neck vertebra, okay, there's a space. And retropharyngeal space. So this is not the best picture. This is the GI tube. So the retropharyngeal space is behind the GI tube and in front of your vertebra. And this is a really important clinical space. So hopefully, rarely. You could have an infection in the oral cavity. So, for example, you could have a tooth abscess. I don't know if any of you have a tooth abscess, but it can happen. That's not common. And that infection, if not treated, could make its way out of the oral cavity, down the retropharyngeal space, into the mediastinum, which is where your heart is. And then you end up with an infection, pericardial sac, and/or other things. So, our presenters are going to show you how to access the retropharyngeal space, okay? The space behind the pharynx, in front of the cervical vertebra. This is the first layer. This is the platysma. I'm trying to motor along here. I got almost 90 slides to get to. No, I think it's less. I think it's only 82. We got this. It's going to be so easy. So, first layer, platysma, and we reflect it and remove some connective tissue. Second layer, this is the layer of sternocleidomastoid. And you're going to look for, I don't know, you might have it in one cadaver, external jugular vein right over sternocleidomastoid. External jugular vein. There's an internal and there's an external. Internal, really, really important, draining most of the blood from the brain. External, not as important. And okay, we talked about sternocleidomastoid function. We talked previously about trapezius function. They're grouped here because actually these two muscles, sternocleidomastoid and trapezius, share the same nerve innervation, which is cranial 11. So, first layer, platysma, scrunches up the neck. This is innervated by cranial nerve 7. Okay? Innervated by cranial nerve 7. The motor innervation too. Why are they talking about cervical nerves here? Am I misstating? No. There's nerves from the cervical plexus that pierce platysma and run transversely across the neck for sensation. So they're called transverse cervical nerves. And there's nerves from cervical plexus that go down to the shoulder region for sensation. And those are called supraclavicular nerves. Another little interesting clinical time. Just try and make this interesting. Anatomy can be boring. So, maybe I already said this. I had a relative with pancreatic cancer, and it spread to the liver, which often happens, and then it spread to the diaphragm, which often happens because the diaphragm's right on top of the liver. You follow me? Okay, so now he's got cancer in the diaphragm. Where did he feel the pain? Didn't feel it where your diaphragm is. He felt it on his shoulders. Why did he feel? He had no cancer on his shoulders. Why did he feel pain on his shoulders? Because the nerves to the shoulders, look at the roots, C3 and C4, are the same roots as the phrenic nerve, which goes to the diaphragm. The roots of the phrenic nerve are C3, C5. So there is a nerve overlap. So that's another case of referred pain, right? Of course, the classic case of referred pain is heart attack pain going to the left arm. But here's another case. Diaphragmatic pain referring to the shoulders. You know what I mean? Okay. So platysma, we'll look for it. And then this is the second layer. We've reflected platysma up to keep it, so we could always look at it, do you know what I mean? This case, they just completely removed it. This is the second layer, and you can see the posterior triangle, right? Posterior triangle is between trapezius, sternocleidomastoid, clavicle. And we can see external jugular vein going over sternocleidomastoid, and now let's just add another piece in here, okay? Let's add another little piece in here. If you were to conceptualize sternocleidomastoid as a little box like that, and find its midpoint, mid-third point, and then this is medial, so it's like the middle of the neck. Okay, and then look right at the side of sternocleidomastoid at its mid-third. You're going to see these nerves coming out, and that's the cervical plexus. And that little point at the mid-third of sternocleidomastoid is Erb's point. And apparently our presenters found out who Erb was. I don't know. Does Erb have a silent H?
In his first name?
It's just Erb with an E. There's no H in there. It's not like French. And so when did Erb live?
It was like 1840 to like 1920.
An anatomist?
He did more neuro.
Okay. Right. There's Erb people. Anyone here a martial artist? Really? None here? Apparently, some martial artists targeted this region of the neck, Erb's point, with punches and kicks. And it's never been exactly clear to me why, but one hypothesis I have is phrenic nerve shares nerve roots with cervical plexus, C3, C5. And so you might be trying to win someone by hitting the neck here. I guess you could temporarily stop blood flow to that side of the brain. I don't know. I'm thinking it's more a phrenic nerve thing. So Erb's point, right about here. So you can start to see cervical plexus appearing. This is also in the posterior triangle where we're going to see cardiac nerve 11, which makes sense. It's heading to trapezius, which is on the back side of the posterior triangle. Another thing you can see, which is cool, and you can see this on multiple bodies. From cervical plexus, wrapping up to the skin in front of our ear, is a nerve. Do you have another name for anything related to the ear is auricular or auricle? So the nerves to the ear are the auricular nerves. So there's a greater auricular nerve that, look at it, it's part of the cervical plexus and it wraps around sternocleidomastoid and it travels with external jugular vein. Check it out. And it's going up to the skin near the ear. Great auricular nerve, part of the cervical plexus. You're going to need to find that. And you're not going to see transverse cervical nerves, but you'll see what I like to call stumpy remnants. So like transverse cervical nerves go to the front of the neck for sensation, but if you remove the skin, you remove those nerves. They're gone. So you're going to see the remnants. And if you remove the skin over the shoulders, you're going to lose the supraclavicular nerves, but we'll see stumpy remnants. Okay? Supraclavicular. Okay, so here's Erb's point, middle third of sternocleidomastoid. And you can see we got some nerve fibers heading to the front of the neck, transverse cervical. We got some nerve fibers that we're going to head down with the shoulders for sensation, supraclavicular. We got a nerve fiber that wraps around sternocleidomastoid and heads up to the ear for sensation, great auricular. So those are all cervical plexus structures we should know, even if you're not going to see them in their full extent on cadavers. Here's another view, okay? Another view, repetition. I mean, think about Duolingo, which I'm completely obsessed with now. It's just constant repetition. Even when you go to new lessons, they tie you back to old ones. It's kind of how I teach you the contention. So here's Erb's point again, middle third, sternocleidomastoid, and this is that second layer. First layer was platysma. Second layer is a layer of posterior triangle and sternocleidomastoid, and you can see external jugular vein coursing over sternocleidomastoid. This is draining blood from outside the skull primarily, external to the skull. And in the posterior triangle, this is where we're going to see things like cranial nerve 11, brachial plexus, cervical plexus, stuff like that. Okay? Some more attachment information on these muscles. Platysma is interesting attachment information. So, yeah, it's coming up mandible, but the distal attachment actually mostly is not to bone. So the muscles of facial expression mostly do not attach to bone. They attach to superficial fascia. So that's pretty interesting. Yep. Which is also why it's difficult to dissect out of the skin. Okay. If you're wondering why is it saying there's some cervical nerves go into trapezius, proprioception, cranial nerve 11, motor. Okay. So we reflected platysma. And actually then you reflect sternocleidomastoid, okay? Now we're kind of at third layer-ish neck. And I said earlier, if you think about the hyoid bone, which is an interesting little bone, it's floating in the neck. There's some muscles above it, and some muscles below it. So, hyoid. The ones above are called suprahyoid. We got an anterior belly digastric. We got a posterior belly digastric attaching to the mastoid process. We got a there's a pointy styloid process, so there's a stylohyoid muscle. This is posterior belly digastric, PE. Stylohyoid muscle, styloid process is pointy. By the way, we got a real skull. I'll take it out Wednesday with like the Mount Everest styloid processes. It's like almost 2 inches long. It's crazy. You don't know how long they are. They're usually like a centimeter. It's like that long. It's crazy. Actually, I think you're going to learn how to palpate styloid process in school. So imagine one that long. I show you that long. So these are the suprahyoid muscles. Cranial nerve 7 pops out right between mastoid process and styloid process. And therefore, cranial nerve 7 innervates posterior belly digastric and stylohyoid muscle. 7. Okay? The floor of your mouth is a muscle called mylohyoid, and the fibers look like this on two sides. See it? Okay? And it's right, like, if my two fingers right now are representing anterior belly digastric, right above anterior belly is the floor of the mouth, mylohyoid. So it's like this. So close. So close. Let's just try one more time. Okay, mylohyoid. Floor of mouth. So, anterior belly of digastric, mylohyoid, which share the same nerve, which is nerve to mylohyoid. Okay. Suprahyoid muscles. One of the reasons I prefer proximal and distal attachments is, let's take anterior belly digastric, which is coming off the mandible. Okay, if the hyoid bone is not secured in place, in other words, the infrahyoid muscles aren't pulling on it, so it's just, then when the anterior belly of the digastric contracts, it's going to pull the hyoid up, which is what these do. But if the hyoid bone is being stabilized by infrahyoid muscles, this can't pull it up. And so actually what anterior belly does is it now depresses the mandible. Two completely opposite functions there. It does not make sense to talk about origin and insertion, right? Okay. So at least using the traditional whatever definition of origin and insertion, or these are both origins and both insertions, that gets confusing. So proximal distal, better. Okay, so then we got infrahyoid muscles. So they're attaching to the hyoid from below. The great thing about all these is almost always their name just tells you the attachment. Yeah. Yeah. Okay. Okay. Sternum, really manubrium, whatever. Okay, so we got a sternohyoid. We got a really cool one that goes like this, two bellies out to the scapula. That's the worst drawing ever of the scapula. What's that one called? Omohyoid. Then we got so we got some cartilage here. Thyroid is like Greek or Latin for shield. It looks like a shield. So thyroid cartilage. So we got thyrohyoid. We got sternothyroid. Everything's got two, whatever. Okay. And almost all of these are innervated by a nerve fiber. That's super cool. So remember the carotid sheath on the sides. If you're dissecting, my dissectors are going to be doing this soon, and they're going to have to be careful. When you open up the sheath, you got to be really careful not to damage this really delicate nerve that's like the size of dental floss. I'm talking like thin, like there's some humongo dental floss. I'm talking like thin dental floss. It's that size. So like when you open up the carotid sheath, if you're not aware of that, you can destroy that nerve. And it's cool. It makes a loop like this. And it then, innervates these muscles. And that's called ansa cervicalis. And it's also part of cervical plexus. Okay. So, suprahyoid, infrahyoid muscles depress the hyoid. Okay? So let's look at it here. Okay. So suprahyoid. And this can be tricky on a cadaver, so try this out on a few cadavers. Posterior belly digastric and sternohyoid are really easy to confuse. So the way to do it is, can you all take a finger and palpate the mastoid process behind your ear? That's part of the temporal bone. Pretty easy to feel. That's more lateral than the styloid process, which is harder to palpate. So posterior belly digastric is heading out here to mastoid process more laterally. Stylohyoid is going a little bit more internally. See what I'm saying? Okay. I think you won't have any trouble finding anterior belly digastric, mylohyoid. in the front, if this is the midline, it looks like this, two anterior bellies, and mylohyoid above it. Okay. Omohyoid is easy because it's a really bizarre one. I remember the first time I saw this, I didn't even know about it. What is this neck muscle doing coming off the scapula? It just completely confused me. Omohyoid. We're coming back, more detail. Okay, so here's that floating hyoid bone. So if you got muscles attaching to it from above, they're going to elevate it, suprahyoid. If you got muscles attaching to it from below, they're going to depress it, infrahyoid. And most infrahyoid muscles are innervated by ansa cervicalis. So, hyoid. See how obvious the anterior belly is. And then you see how mylohyoid is forming the floor of the mouth. And those two muscles, anterior belly digastric and mylohyoid, share the same nerve innervation, which is nerve to mylohyoid. And our presenters are going to show us nerve to mylohyoid. That is also dental floss thin, isn't it? It's kind of crazy that you can even see it. See how easy it would be to confuse posterior belly digastric and stylohyoid? So the one that's going more lateral is going to the mastoid process, that was posterior belly. And the one that's going a little bit more medial is stylohyoid. Okay, so those are the suprahyoid muscles. Infrahyoid, I think, are pretty easy to understand too. Omo is going towards the scapula. The really long strap guys, sternohyoid. Underneath it, look at that, there's sternothyroid. And then from thyroid cartilage to hyoid, thyrohyoid. Those are easy to, I think, figure out. Yeah?
This may be a stupid question, but when omohyoid contracts, does it not kind of impinge on the vein that it's going around?
It does kind of what?
And does it not like kind of like, I guess, squish the vein that it's on when it contracts?
Does it squish the stuff that it's going over?
Yeah.
Is that what you're saying?
The vein that it's going
Never
over.
heard of that. I haven't heard of that. There are, good question, there are many situations where one structure can impinge on a neighboring structure, or if you, for example, if you add a 13th rib, cervical rib, to the rib cage, which a striking number of humans actually have a cervical rib, that adds a lot of congestion to the neck, then you're more likely to, because of that congestion, to have things impinging on other things. You can end up with what's called like thoracic outlet syndrome, but I've never heard of omohyoid impinging on vessels. Interesting, you could look it up, I don't know, never heard of it. Be careful with ChatGPT though, it'll make up references sometimes. So, although I've checked it often, it's pretty accurate. So just this is from TEMA Atlas. I like this, just compared to Netter, just real clear, not too much clutter. And so again, see how the posterior belly is going to the mastoid process, and the stylohyoid is going to the styloid process. One more time, the cranial nerve 7 pops out between mastoid process and styloid process. Styloid process looks like a point, like a stylus of a pen. Mastoid, I don't know what that means. It looks like a mastoid. And in between them is where cranial nerve 7 pops out. And so since 7 is coming out right here, it makes sense that 7 is going to hit these two muscles, stylohyoid and posterior belly digastric. Okay, so cool. Moving on. Just more information if you wanted it. Okay. Now, strap muscles, also called infrahyoid, I think I know we've gone over this already. Let me just tell you where would you find the nerve that innervates these? It's the ansa cervicalis. It is embedded in the carotid sheath. Now, in this neck, this picture, they've removed the carotid sheath. You can see two of the three things in the carotid sheath. You can see the internal jugular vein, and you can see carotid artery. So they've removed the carotid sheath, but if they hadn't, you would see this nerve that loops down like this. And that loop of a nerve is called ansa cervicalis. Maybe someone can look up, I don't know what ansa means either. I don't know what that means. If it's from Greek or Latin or something. Here's the one exception. Thyroid. Everything else, ansa cervicalis. Okay. So, let's come back to Erb's point. Erb's point is the middle third of sternocleidomastoid muscle. Okay, get these cervical plexus nerves popping out. And we got one heading up towards the ear, great auricular. We got some that cross the neck in front, transversely, so transverse cervical. We got some that head down to the shoulders, supraclavicular. And we got a loop formed by cervical plexus called ansa cervicalis. Part of ansa cervicalis hitchhikes along the nerve that's going to your tongue, which is cranial nerve 12. This is the nerve to your tongue. And then C3, C5, phrenic nerve. So a lot of cool stuff related to cervical plexus. Okay. We're going to be able to see great auricular. We're not going to see lesser occipital. We're going to see remnants of transverse cervical and supraclavicular. We're going to see ansa cervicalis. Okay. And we're going to see cranial nerve 12. See all that. Another view. So here's 12. Hypoglossal means it's a nerve going to the tongue from below hypoglossal. This is 12. And you can see coming off 12 as part of ansa cervicalis. And ansa cervicalis is going to our strap muscles. Okay. Okay. Supraclavicular to the shoulder. Transverse cervical to the neck, front of the neck, anterior neck. And just another view. I put in a number here. You can look at it on your own time. You're going to see great auricular. You're going to see ansa cervicalis. You're going to see phrenic. You're going to see cranial nerve 12. And then the rest, cranial nerve 12 isn't cervical plexus, but the rest of the plexus you're going to see as remnants, little cut off twigs coming out from deep in the neck. You'll see that on most of the cadavers. You can look at this table on your own time if you want more info. This is a really deep dissection in the neck. Okay, we're below sternocleidomastoid. We're the median part of the neck, and we're below the strap muscles. So to see this, you'd have to remove the strap muscles. You'd have to remove sternohyoid, stuff like that. Even sternothyroid has been removed. Okay, and so now we're at the endocrine level of the neck. We can see the thyroid gland. Earlier I asked you to take a finger, palpate your Adam's apple, rub it down, draw it down your thyroid cartilage to where you feel the cartilage end, and your finger is now right here. And that's where you can do a cricothyrotomy. Of course, you can do a cricothyrotomy. Of course, you could do a tracheotomy down here. there's pros and cons of each. Anyways, so thyroid gland's pretty cool, really pretty complex endocrine organ, involved in metabolism, growth, calcium regulation, calcium metabolism. One little tie-in to some things we've seen before. So just to remind you, 3 main structures in the carotid sheath. This is like the 4th time I've said this. So internal jugular vein, carotid artery, and the 3rd thing is vagus. So here's vagus. And vagus has that name. Think about other words with that root. Vagrant, vagabond. It has that name because it wanders around the body. Probably has like the most convoluted pathway of any nerve. And it's here heading down into the thoracic cavity. And what it does is, and I think I alluded to this last week, it gives off a branch, almost like it made a mistake. It goes back up the neck to the larynx and to the vocal cords. So it's called recurrent laryngeal. And I'm bringing this up because recurrent laryngeal is going right behind the thyroid gland. Here it is. Here's recurrent laryngeal on the right side. Going right behind the thyroid, going up to the vocal cords, which are back here. And so, for example, I have a relative who had part of her thyroid gland removed. They suspected cancer or something, I don't know, something else. And so the surgeon has to be really careful if you remove the thyroid gland that you don't, by accident, damage this recurrent laryngeal nerve traveling right up here. Okay? If you were to do that on one side, it wouldn't be the end of the world, but if like you were a professional singer, that would ruin your career. Unless you wanted to sound like Bob Dylan for the rest of your life, and then maybe that's a good thing. If it happened on both sides, you're probably not a great surgeon, and then that is a real medical emergency. You're no longer able to open your vocal cords, which we don't open just to make sounds, but also to breathe. So, medical emergency. One side changes your voice dramatically. Both sides, not something you want to have happen. So, just a little teeny clinical correlate. Because this is an endocrine organ, right? Endocrine organs secrete chemicals into the blood, okay? So thyroid gland is secreting chemicals into the blood. It has a rich blood supply like all endocrine organs do, like the pancreas, et cetera. So the one vessel to the thyroid gland you're gonna need to find is actually the first branch of external carotid artery. Here it is, superior thyroid artery, because it's coming down from above. There actually is an inferior thyroid artery. I'm not asking you to find it. Okay. So remember, common carotid at about C4 divides into an internal carotid artery and an external. This is the midline. External is closer to the midline. So what I'm saying is the first arterial branch off external carotid artery. External has the name because it's supplying blood external to the skull, outside of the skull. The first branch off of external carotid is superior thyroid artery. It's going to the thyroid gland. Okay. So we'll see that in cadavers, multiple cadavers. Okay. Doing okay. I think I'll get to 40 before we take a break. Now let's go really deep in the neck. And so if you're right on the vertebra of the neck, there's 2 muscles, longus colli and longus capitis, that flex the head of the neck, flex the head of the neck. And you can see that on multiple cadavers. What you gotta do is you gotta think about it. We've just been working our way from platysma to sternocleidomastoid to carotid sheath. We removed the strap muscles to see the thyroid gland, you know what I mean? So what you'd have to do is get your fingers behind all this stuff. Get your fingers behind the pharynx even. And some of our bodies, it's pretty mobile. And you can now touch the vertebra and you'll see those muscles, longus colli and capitis. All right. I'm not gonna ask you to identify rectus capitis anterior or lateralis. of minor importance. Scalenes, we will want to know, but kind of going to hold you more responsible for those when we get into the upper limb, which is next unit, okay? Although you can see the scalenes in the posterior triangle of the neck. The reason I'm holding off on the scalenes until the next unit is brachial plexus appears between scalenes. It's like a scalene sandwich, getting to your point. Is it Isaac? That's a classic place actually. The scalenes, because they're a sandwich around brachial plexus, they can cause nerve impingement. Or to vessels going between the scalenes. Okay? So pharynx, otherwise known as the throat, technically has 3 parts. One of the things we're going to do, this is cool, this is our only opportunity, we're going to look at some heads that have been split in half, which I just think is so cool. But anytime I do it, I come home and I tell my parents, I don't work for my parents anymore, but like, when I see, I'm pretty excited. And my dad's like, okay, we're done with this conversation. We can go back to talking about football or whatever. So I don't know, I think it's cool. You're gonna be able to see a bisected head. We kind of waited till now because a lot of you understandably wouldn't have reacted well to your first cadaver experience being looking at a human head split in half, okay? But we're 7 weeks into the semester, which is kind of hard to believe, so we can handle it, okay? Hopefully no one's gonna faint. And so the top part of the pharynx is called nasopharynx. This is cool. This is where the eustachian tube is. If any of you were unlucky enough during the pandemic to have a COVID test, not the one where they swirl around in the front of the nose, that's easy. Where they drove it all the way back, horrible, okay, weird sensation. They were driving that Q-tip all the way through the nasal cavity, all the way to the back of the nasopharynx, and scooping around back here, and that's why people were like, oh my God, it felt like you were touching my brain. They weren't touching your brain, but actually pretty close, you know what I mean? And nothing should ever be touching in there, you know what I mean? We got a soft palate that elevates when we swallow so that the donuts that you're eating or sushi or the hamburger or french fries don't end up in the nasopharynx. Like nothing ever touches that part of our body. That's why when you had a COVID test back there, it was like such a weird sensation, you know what I mean? Then we got the part behind the mouth, which is probably the most important part, when the tongue moves the bolus of food. Bolus of food is a masticated chunk of food and saliva back into the throat. It ends up in the oropharynx. By the way, when that's happening, the soft palate elevates to close off the nasopharynx. Again, you don't want sushi in the eustachian tube. Now, this is interesting. Now we have a laryngopharynx down here. We are kind of unique among mammals, primates, in having a pretty markedly descended larynx. And the reason we believe that happened during evolution is to allow us to produce the kind of sounds that we do. And so that's the upside to a descended larynx. The downside to a descended larynx is, okay, let me just step back. There's actually 2 structures that move when we swallow to prevent food from prevent food from going to places it doesn't belong. The first structure that moves is, this is the hard palate, and this is the soft palate hanging off of it. The soft palate elevates to close off the nasopharynx so that food doesn't go up into the nasopharynx. But there's a cartilaginous structure that actually drops called the epiglottis. And this closes off your respiratory tract so that food goes only into the GI tract. I should have done that with different colors, but anyways, you follow me? So the epiglottis drops, the soft palate elevates, food doesn't get into the nasopharynx, and food doesn't go into your lungs for obvious reasons. In primates, there is no space between the soft palate and the epiglottis, other primates besides Homo sapiens. And so food just goes immediately into the GI tract. There is absolutely no possibility of choking to death. We're basically the only mammal that periodically chokes to death, okay? And so we've basically come up with a compromise. In order to make our complex vocalizations, we have a descended larynx theoretically, but some of us are going to choke to death as a result. Okay? Another little adaptation to being human. This is the nasopharynx in close up. We should all learn the Heimlich maneuver because I guarantee you, some of us in here at some point will have the opportunity to save someone's life. As you get older, you lose some of the control over the musculature of your throat. Much easier to choke to death. To choke, hopefully you don't choke to death. Much easier to choke. You know the Heimlich maneuver, you can prevent a relative from dying, which would be tragic. So this is the soft palate that elevates and it closes off the nasopharynx. In the nasal, this is where we were doing that COVID test. We've also got some lymphoid tissue back here, otherwise known as tonsils. Pharyngeal tonsils play a role in immune surveillance. And this is the entrance to the internal auditory tube, also known as the eustachian tube. By the way, it's shorter in little babies, so it's easier for a respiratory tract virus to make its way into the middle ear, so it's more common for little babies to have middle ear infections, right? Why does a respiratory virus hang out there? Because many of them have evolved to socket to the mucous membrane covering our pharynx, nasopharynx. COVID was exactly like that. Actually, that's why they drove that thing back through your nose back there. COVID virus is perfectly evolved to target that mucosal area, not deeper in the lung. Do you know what I mean? So anyways, we're gonna look at the nasopharynx a little bit. You know, this is our only opportunity, right? One day, one lab to do this. Kind of cool. There's a little muscle that comes up here. You can see it. It's gonna become cartilaginous or insert some cartilage. This is called salpingopharyngeus muscle. You can see the name right here. I think salpingo means tube. And it opens up that tube. Like, have you ever had this experience where you're actually trying to equalize air pressure in the middle ear with the outside air? That's why we have the eustachian tube, and you yawn, or you just swallow even though you're not eating. You're trying to activate salpingopharyngeus to open up the tube. Trying to open up the eustachian tube. Okay. Have any of you had a really severe cold and gotten on a plane? Don't recommend it. What happened? What happened? Was it pretty bad? Well, did you have any pain?
Yeah.
Like, was it horrible?
I didn't have.
Oh, I was coming back from Mexico once and a horrible cold, got on the plane, mid-cold, and had maybe the most intense pain I've ever had in my life. And that's because I couldn't equalize the air pressure in my middle ear. My eustachian tube was clogged. People around me just must have wondered if I was crazy. I was just I was trying not to verbalize it. People walking by in the aisle on the plane, like, dude, you can have police waiting for the plane, man. Honestly, that seat's insane. Don't do that, people, or get, I've learned since then, if you got a really bad cold, you gotta fly, get some of these decongestants, even if you don't like to use those chemicals, because you do not want to experience, it's like putting your head in a vice, man. Don't want to experience it, it's horrible. Yeah.
Is this something that just would happen now? I'm thinking about like babies crying on planes. Is it something that they would naturally do, or do they cry because they don't know how to?
I don't know if babies know yet to yawn or swallow. If that's something you gotta learn. You know,
I know that new mothers will try, or not new mothers, will try to feed them.
I have heard that,
Yeah.
but I just didn't know if it was like something.
Cool,
that you
yeah.
would instinctively do. I don't know.
But middle ear infections are more common in babies. Yeah, I was gonna tell some. Should I? But that wasn't the end of my trip. And then again, it's a passport and customs, and they stopped me because I used to have long hair down here, and I had a guitar. So I think they're thinking, oh, that's a hippie, and he's got drugs in that guitar. It's not a guitar. He probably was just doing the sternocleidomastoid. So they literally made me. They're like, oh, you got a guitar in there. You want to play it for us? They literally made me take my guitar out and check to make sure there were no drugs in there. Okay, anyways, sorry. Okay, so this is the pharynx, this is the throat, and there's two sets of muscles, okay? One set of muscles are circular, and you're not going to have to differentiate superior, middle, inferior. This is the whole circular pharyngeal constrictors. We'll see these, okay? And what they do is they sequentially contract and push the food into the esophagus, okay? But at the beginning of swallowing, we got a second set of pharyngeal muscles that are actually elevated. They're coming down from the top. They're kind of vertically oriented. You can see them here, coming down like that. Like salpingopharyngeus. So salpingopharyngeus has another function besides opening up the eustachian tube, elevates the pharynx at the beginning of swallowing, okay? So two sets. The circular constrictors push the bolus of food into the esophagus, but even before then, we have to elevate this whole apparatus. We got to elevate the hyoid bone. We got to elevate this whole pharyngeal structure for swallowing to take place, and we're going to use things like salpingopharyngeus, stylopharyngeus to do that. Does that make sense? Okay. So these are circular constrictors viewed from the side. You're going to be able to put your fingers behind these into the retropharyngeal space, and then here on top of the cervical vertebra would be longus colli and longus capitis that are flexors of the neck. Okay. 9 and 10 are the big players in the pharynx, in particular 10. 10 innervates every single muscle with one exception. You know, and then sensory to the pharynx is a lot of nerves, in particular 9. So that's why the gag reflex, we say, is a 9-10 reflex. Right? You eat some Doritos, or maybe more like a fish with some bones, and it stabs the back of your throat and triggers the gag reflex. 9 sensed the fish bone. 10 expels the fish bone, if you're lucky, or the fish gag reflex. Okay. These guys here are the vertically oriented pharyngeal muscles. They are not pushing the bolus of food into the esophagus. They're elevating the pharynx at the beginning of swallowing. Okay. These three muscles: stylopharyngeus, salpingopharyngeus, which we just saw in the nasopharynx, pallidopharyngeus. If you want, I can show you pallidopharyngeus on a cadaver if you wanted to see it. Actually, the bisected head probably has it. I could show it to you in a second. You could look for more detail here. And so when we swallow, we're going to take a break in 2 minutes. When we swallow, we masticate the food, we add saliva. Actually, chemical digestion starts in the mouth, not in the stomach. If you ever, you can try this experiment, it's kind of fun. Get a saltine cracker, which is like the worst cracker ever invented. Who invented this stuff? But it could probably survive for hundreds of years. Maybe that's the upside to saltine crackers. But anyways, you chew on one of those puppies, there's no flavor, and it definitely doesn't taste sweet, does it? But if you do a meditation with your saltine cracker, just chew it for a minute, you'll find it actually starts to taste sweet. So we're starting to break down sugars in the mouth. Anyways, so kind of cool stuff happening in the mouth, and saliva has some antibacterial properties. That's pretty neat. And then, so that now, food, masticated, broken up food with saliva in it, is now a bolus, and the tongue is going to push it back into the oropharynx. Soft palate's going to elevate to close off the nasopharynx, and epiglottis, check it out, is going to drop down. And what I was trying to say is, other than Homo sapiens, other primates do not have a space at rest between soft palate and epiglottis. They do not have an issue. They do not have an issue with choking. We do. And eventually, that bolus of food is pushed via sequential contraction of the circular constrictors into the esophagus. Make our way down to the stomach by peristaltic contractions. The upper part of this esophagus, if you wanted to know, is under voluntary control, but the bottom part is sleeve muscle. That's just autonomic nervous system. We actually don't have this on any cadavers in Sac State, but this is kind of cool. If you go in from the back, it's kind of complex to do this. You have to, you got to remove the cervical vertebra. We just don't have enough bodies. But so if you could imagine, we're coming in from the back, and we've just removed all the cervical. This is the back, and we've removed all the cervical vertebra. And this is the circular constrictor muscles, the pharynx. And we just took a scalpel blade and zipped it open. And in doing that, now you can see laryngeal structures. Kind of cool. We don't have this in Sac State, but we have a couple bodies where we've split the head in half, so you're still going to be able to see the stuff from the mid-sagittal view. You won't be able to see it from this posterior view. And here's that soft palate, and here's the epiglottis. There's the space. And the problem with having a space between the soft palate and epiglottis is if you want to eat, there is a chance that that food will end up in the wrong tube, go down typically into the right lung. You can breathe while you're chewing, which is interesting. See it? But when you're swallowing, you can't breathe, okay? So, right, we've shut off the respiratory tube. The epiglottis is covering the respiratory tube, the larynx, etc. Can't breathe. Let's break here. Let's come back at 10 up.